So the reason why this is so concerning, the neurotropism of this virus is so concerning to me, is because the lung and heart, the cardiopulmonary symptoms of this virus they mask the neurological symptoms. So if someone has some breathing trouble, you might assume it's just pneumonia without considering that it might be brainstem dysfunction. If someone has myocarditis or pericarditis from the virus attacking their heart muscle, and then they have an arrhythmia, you might assume that that arrhythmia is caused by the virus directly attacking the heart and not by the virus attacking the brainstem's control of the heart. So the only way to unravel this pathology and get at the anatomy of this disease is to section and examine every single one of these tissues. Every single one. You have to when you have your coroner, performing an autopsy on somebody, they have to cut out the lungs, section and examine the lungs, the heart, kidneys, liver, brain stem, blood vessels, peripheral nerves, vagus nerve. Every single one of these tissues has to be examined for histopathological changes. You have reports coming out of China of patients with a virus found in their cerebrospinal fluid. You have reports of patients with hemorrhagic encephalopathy. Their brain is bleeding because of this virus, bleeding and dying, necrosis of the brain and hemorrhaging of the brain tissue. And some of these are rare complications, of course, but you cannot discount the possibility that many of these critical or severe patients may have dysautonomia because of the neurotropism of the virus and the cerebral and the brainstem abnormalities. It could affect their breathing and their heart rhythm. It's something that needs to be investigated, and I'm not seeing that. What I am seeing is the CDC is publishing guidelines that are pushing the idea of COVID-19 as primarily a lower respiratory syndrome, when it's a syndrome that affects the lungs, heart, kidneys, liver, brain, blood vessels, male reproductive system. Many tissues in the body, not just the lungs. So this is something that needs to be investigated. We need to be checking to see if I've been hearing reports from numerous doctors. Okay, they can't crack the code here on this thing. Like, what's the mystery with this virus? It's like, what's going on here? Why are these patients having low O2 saturation without shortness of breath? They can be sitting there jawing along just fine, but they actually have like 70-80% O2 saturation. They're getting blue in the face, but they don't have any pneumonia yet. Why is that the case? Well, based on the information that I've gathered, there are two things that could be causing that. One of them is pulmonary hypertension, and the other one, from the angiotensin II backing up, the other one is simply vasculitis, pulmonary vasculitis, from the virus actually attacking the blood vessels of the lungs, of the alveoli, the inflammation, leading to hypoxemia. And that's something that needs to be investigated. These patients are going on the vent. They're getting intubated, and a lot of these patients that are being intubated are dying because the ventilators have settings that are specifically tuned for ARDS, for acute respiratory distress. But these patients don't have acute respiratory distress. What they have is hypoxemia with no clear cause, which could have a neurological cause from depressed breathing. They don't realize they're not breathing enough, or if they have normal recruitment, if they have normal breathing, apparently, it could be pulmonary hypertension or vasculitis. And there are so many, the pathology of these beta coronaviruses is so complex that any one of these things is possible. And it's disappointing that so little information has come forward on what these viruses do, what they actually do to the human body. There are people who keep insisting, it's just a coronavirus, it's just a flu. No. Beta coronaviruses are bat SARS. All right? Bat SARS is not the flu. It's bat SARS. Okay? Completely different. The key difference between this virus, the key genetic difference between this virus and SARS-CoV-2 and SARS-CoV is that SARS-CoV-2 has, on its spike glycoprotein, it has what are called furin cleavage sites. And what those are is these are protein cleavage sites that allow the virus to fuse very efficiently to human cells, like HIV. That's the reason why it's spreading so quickly. The 2003 SARS outbreak petered out, and you didn't have very much transmission of that, but, it could have become a big problem if they let it get out of hand. This virus was allowed to get out of hand in a big, big way. And not only that, it is vastly more infectious and more neurotropic than SARS was. So you're dealing with a virus here that is basically super SARS. And you have the World Health Organization telling us, oh, it's this thing called COVID-19. It's not really that big of a deal. We're trying to avoid any associations with the previous SARS outbreak. Let me tell you what happened in the previous SARS outbreak. SARS has oral fecal transmission. You've shed this virus in your feces. In Kowloon, in the Amoy Gardens apartments, people would defecate in their toilets. It would go down the drain. And then it would go into the down the drain pipes of their apartments, and it would come up through the floor drains and through their dry pee traps in their floor drains in their bathrooms. The vent fan in their bathroom would pull a suction on the room and create a negative pressure situation that would pull fecal particulate matter up out of the floor drains. 300 people in the Amoy Gardens apartments in Kowloon got sick with SARS because this virus came up through their floor drains. There were whole studies on this. Look them up. SARS, Kowloon, Amoy Gardens apartments, AMOY, Amoy Gardens. Look it up. They had studies on how it came up through the plumbing. And I'm watching China quarantining people in these high-rise apartments. And who even knows that these apartments have infrastructural problems that are infecting thousands of tenants? They're trapping people in these buildings and welding them up inside and barring them up inside, and they could be turning into disease hives. They could be condemning these people to death by locking them up inside these buildings. It was very, very frustrating to watch. The sheer ineptitude of what I was witnessing was just appalling. It was unbelievable. Unbelievable. It's unbelievable. And we're not even fully sure if it's only if it's only droplet borne or if it's aerosol borne. We're not sure if it can go 6 feet or 15 feet. The CDC's guidelines to say stay 6 feet from everybody could be totally inadequate. You might actually have to stay 15, 20 feet away to be safe from a carrier of COVID-19. And our healthcare workers, our doctors and nurses who are fighting this thing and who are basically our generation's Chernobyl liquidators, they have N95s and surgical masks and very often lack eye protection, which is a necessary component because this virus can actually enter through your eyes. So ideally, you would have a powered air purifying respirator hood on, or a full face P100, or even a full face military, NATO CBRN mask on. And these people are actually these very brave healthcare workers are facing down a deadly neurotropic virus with nothing but surgical masks and scant supplies of N95s.